Enteral feed intolerance is currently a very common problem in critically ill patients, which we encounter in our daily practice in ICU. Up to almost 50% of these critically ill patients suffer from enteral feed intolerance at some time of their ICU course. However, we generally follow a reactive approach to diagnosing enteral feed intolerance or EFI. We generally encounter increased gastric residual volume, vomiting, abdominal distension, or symptoms like diarrhea or failure to achieve feed target, by which we come to know that patient is not ready to accept enteral feed or he is not tolerating enteral feed. But what if we could predict intolerance before it occurs? So machine learning or artificial intelligence can combine multiple variables and detect complex non-linear patterns that are difficult to capture with simple clinical scores. So what is the benefit here? So we feed the patient data into a ML model and we get a EFI risk score which will help us to individualize our feeding strategy. So let's go to some examples of these models which have been created in recent years by several authors. The first one is the model by Liu et al., which was published in 2002, and they question, can we predict EFI before it happens by a simple logistic regression model? They included 203 ICU patients receiving enteral nutrition, and out of which 77 developed EFI. The independent predictors of EFI were age, the presence of GI disease, early feeding, mechanical ventilation before enteral nutrition, and abnormal serum sodium. What they concluded was baseline clinical information, which includes these 5 parameters, can help predict enteral feed intolerance before the feeding is started. With the area under the curve of 0.7, which suggests modest diagnostic accuracy. Another model by Raffaelli et al., published in 2023, included a very large dataset of almost 1500 ICU patients, out of which 64% developed EFI. They used a complex model by the name of gradient boosting, and still the result was almost similar for 0.7. The most important predictors were the patient's BMI, whether he was obese or not, a gastric residual volume of more than 250 on day 2, the SOFA score on day 1, and the age of the patient. So there are several models. There are several other models also which are published and which aim to predict EFI before it occurs. However, the data is not very strong, and now comes the question whether we can use these AI prediction models or the prediction given by them to in the ICU at the bedside from tomorrow. So answer is not yet. These models are not yet ready for bedside use. The reason is mostly the data fed into these models is retrospective and from single center datasets. They don't have external validity. Different definitions of EFI was used in different datasets by different authors. The area under the curve or the diagnostic accuracy was not perfect. Only moderate discrimination was provided by them. And most important, there is no evidence yet that using the prediction model improves patient outcome. So in near future, we hope that we get better and validated models which will integrate into the electronic medical records of patients and which automatically will predict a patient's risk of EFI. And if the risk is high, a clinician can decide whether to hold enteral feeds, whether to start slower, whether to use other diagnostic modalities like gastric ultrasound, whether to preemptively start a prokinetic or use post-pyloric feeding or else. So that's it for use of AI in predicting EFI.